All right, it's Thursday. You know what that means. So we've got 5 studies on the ticket today, and the first one we're going to start with is the presence of abnormal palpatory findings in the sacrococcygeal area. They correlate that with chronic pelvic pain. So basically, palpatory findings, findings that practitioners feel for in the sacrococcygeal area, so basically around your tailbone region. They found in this one that it correlates to chronic pelvic pain, but there's a few points that I want to talk about it, or a few points in this study that I want to talk about. So first up, our abbreviations, APFs, abnormal palpatory findings. They just, again, generally categorize them. I need to see if I can get access to more of the full PDF to see exactly what they discuss as an abnormal palpatory finding. Was it a perceived trigger point? Was it entirely subjective on the palpating provider's part? Was it correlated with a pain response from the patient? Was it a visual analog scale thing where the patient said, yes, when you poke here, I feel XYZ? I have my initial suspicions, which again, until I've seen otherwise, I'll assume, which we all know how that goes. But so we have APFs, abnormal palpatory findings, and chronic pelvic pain syndrome, CPPS. They wanted to see if they were linked. And not surprisingly, we can essentially take this study and bring it anywhere else, any other region in the body. Probably one of the most commonly talked about other regions is going to be along the traps. Like, how many times have I heard a patient say, oh yeah, I carry my stress right here, and that's correlated with shoulder pain, neck pain, headaches, etc. So it's not surprising that when they actually broke down the results, so from the methods, 300 participants, the manual procedure, palpation, was performed by 2 physiotherapists certified in their own version of manipulation, yada, yada, yada. That's not super important. They assessed symptom severity and psychosocial variables using a pre-named determined index. This one's the chronic prostatitis symptom index, so pain around that region index, and a generalized anxiety and depression scale, which is important when we're discussing chronic pains and chronic conditions. And what they found was the abnormal palpatory findings were significantly associated with that chronic pelvic pain or the chronic pelvic pain syndrome, particularly in the sacrococcygeal and pelvic floor regions, indicating a moderate to strong correlation. Now, again, we could take the approach of chicken and the egg. We could take the approach of clinical relevance. There's a lot of different ways that we could discuss this. First, it's not surprising. This seems to be something that happens in general when we have chronic pain conditions. Whether or not the chronic pain starts first, and then oftentimes we develop secondary, that's not exactly a comorbidity, but secondary symptoms worth managing, such as anxiety, depression, social interactions, monetary drain from trying to treat the pain. Or if we already have those, which means we're predisposed to developing the chronic pain in the first place, we see this pop up everywhere. Again, I mentioned in the traps, it frankly happens anywhere in the human body. It just seems to be a thing. Now, something that I feel that I should discuss is how I'm going to relate this to how a lot of patients talk to me about weakness and muscle pain. So when it comes to these abnormal palpatory findings, is it something that I subjectively find in practice? Yes. Is it very often that my perceptions of what's going on in the area overlap with where the patient is having these symptoms? Yes. Does that mean that I'm finding necessarily a cause to something? That's where it gets a little bit more hinky. Not as a defined yes or no. Depends on the condition, depends on the patient scenario. Is it something that just with my hands could I track progress consistently throughout every single person's treatment plan? No. What do I mean by that? Basically, even if you were to find these abnormal palpatory findings, which again, we would have to define exactly what would constitute an abnormal palpatory finding, they try to make the conclusion that these appear to be an important clinical marker for this chronic pelvic pain syndrome, and their presence may help identify patients who could benefit from targeted manual therapy. I take two issues with that. The first is people with this condition, there's a reason that that condition is there, which means that if you are taking a targeted manual therapy approach, you cannot do it in isolation because you are not changing the system, you're just affecting the symptoms. So if somebody has chronic pain in that region and all you do is some manual therapy to try and go after the abnormal palpatory findings, you're not addressing why they're there in the first place. So you may make the patient feel good, you may not. And I've seen this in my practice. If you don't address what is causing those abnormal palpatory findings to happen in the first place, they will just come back. Does that mean that I'm saying you shouldn't do manual therapy? No, because it can open up a window for us to address the actual reason that they're there. So that's my first addition of nuance to that statement. Could benefit from targeted manual therapy, yes, but it must be followed up with this multimodal management. Okay, so I don't want you just to read that sentence like, aha, practitioner, you just need to, no, read the whole thing. Part of multimodal management. Now, the second issue I have is the subjectivity of it. There is a device out there that tries to get relatively objective with palpatory findings, and that's called an ergometer. And what that is essentially a pain measurement device. It essentially, let's see if I can find something here. Oh, let's just pick this. So this is just a little wheel. What happens is the ergometer would actually be attached to this wheel here, and I would be applying pressure at a controlled pace over time. Essentially, I'm increasing the pounds per square inch over the painful area, and the patient would report when it goes from I feel it, it's uncomfortable, or I feel it, it's uncomfortable, now it's painful. You're able to then track that to see if it desensitizes over time. So can you track it? Yes, to a degree, but it requires patient input and an actual device that's not just your hands to objectively measure that over the course of care. So again, am I against using palpatory findings to see if a patient is doing better over care? No, but I'm also very aware that unless I measure it, it is subjective, and it is not something that I need to rest my hat on as the only way that a patient, or I know a patient, is getting better. It's why we use objective markers in our practice. It's why for the right patient, we measure muscle strength. For the other right patient, we actually measure range of motion, because if it doesn't get measured, it doesn't get managed properly. So even if I like the approach that this study discusses and is something that I utilize in practice, unless we take it a step further, like the back part of this sentence says right here, multimodal management, and we need to actually be measuring this as objectively as we can, it's something that is very, very subjective to the individual practitioner. Another study that comes to mind is subjective muscle testing, and I gave a talk about this a couple months ago. The classic method that you rate it on is a 5 scale, 1 through 5, 5 being normal, 1 being you basically can't even lift it against gravity, and everything in between. And a majority of practitioners, when they actually broke out blinded, whether it's physical therapists, chiropractors, basically people who can do these objective muscle tests, the range and the acceptance rate of who could agree to what and how many people with a legitimate condition slipped through the cracks because it was just up to the practitioner's setup and muscle strength at the time was extreme. I think it was half of the people with a legitimate diagnosed condition that would lead to muscle weakness slipped through as normal. And then the rate of practitioner agreeability on hitting the same number was ranging from 25 to 50%. So again, it's another reason why we need to measure these things. So I like it. It's cool. It fits a part of what my practice does, but I think there's more that needs to be done for clarification and adding nuance to the actual patient experience before something like this can be accepted on a wider basis. Is just kind of how I'll leave it. But I got to keep going. I'm already behind my time as it is. Correlation between muscle strength and clinical condition in individuals with greater trochanteric pain syndrome. So similar to how we talked about last week, pain on the outside part of your hip. I like the way that they do this because the highlights essentially let me talk about it without having to go through the entire study for you guys. There was positive correlation between hip abductor strength, so being able to raise your leg out to the side, and visual pain analog scale scores. And basically it said that it alluded to the fact that if you were stronger in what it measured, you had less pain, less development of pain, and less severe pain. And it's one of those things where, again, not surprising, but I don't want, there has to be this nitpicky nuance that I got to introduce. Increased strength does not always correlate to reduced pain. I've treated a lot of high-end athletes, very muscular, strong, athletic individuals. They still have pain. Strength is not the be-all, end-all, but I also don't want you to take that to mean that you don't have to do your due diligence and get your keisters outside, move around, and actually use your bodies. So don't take it as an excuse. What strength allows us to do is build a level of capacity for the different demands of life, which means should you have adequate strength and athletic capability, basically the ability to use your body without a strain on your musculoskeletal resources, what would cause pain is less. Like the amount of things that would cause pain for that area are less because your body's not straining its resources to do what you're demanding of it. Versus somebody who is deconditioned, has no muscle strength, yada, yada, yada. If they go to do certain tasks, your body is now being strained beyond what it is capable of. So the things that would cause pain now aren't just your pathologies, your bursitis, your arthritis. Now it's also a reduced ability for you to perform the task, and it's going to be, inflammatory stressors, chemical stressors, the stressors that your body naturally will go through trying to do the event itself, the metabolic demand of it. You do not have the resources at hand, and your body will then go into a stressed state. And part of that stressed state could lead to pain, whether it's acute, such as a sudden sprain, strain, delayed onset muscle soreness beyond what we would want, or it would be some just level of unwanted tissue breakdown beyond the ability to recover. And then it could lead into chronic pain. So it's a long-winded way of saying anybody can have pain in a joint region regardless of the amount of strength that you have. However, should you be stronger and more capable, now I'm less concerned about it being a capacity issue and that your body's going through a stress response because of what you're putting it through. It's more likely the acute, like, okay, you went from being athletic to doing, because it's going to be Memorial Day here soon. You just went and did the MRF, which is you can train for it, but then a lot of people take it to the next level, just perform on that day. They take their body through a ton of additional stress. There's acute responses to that in the short term that as long as you recover afterward, these people are fine. However, if you don't have that level of capacity, then I now have to consider just the fact that you were deconditioned that's leading to this issue, and part of what could reduce your pain could be just adding that capacity in. I feel like I'm kind of circling here. So if that doesn't make sense, just leave a comment, hit me up. Basically, strength does not automatically equal no pain. It just means that the things that could cause you pain are typically not as broad and aren't as likely to be in the category of you lack the capacity for that movement pattern, or that task outside of a high stress environment, situation, or competition. So that's all I'll say. These next few should be quicker. Manual therapy for cervical radiculopathy. Let's get that off. Let's snooze that. Manual therapy for cervical radiculopathy, effects on neck disability and pain. This is a meta-analysis. I see this in practice. The only thing I don't like is that they just, okay, first, it's great in the sense that it's a meta review. They're looking at a whole bunch of different studies. They found 8 eligible studies in their criteria with over 600 participants in the mid-40s. The duration of these studies went from 4 to 6 weeks. They divided into 3 groups, which were just exercise and other therapies, which nebulous, but not manual therapy. So just exercise and maybe some other things, non-manual therapy. Manual therapy with no traction, and manual therapy with traction. And what they found was the manual therapy group had a particularly robust response to reducing cervical radiculopathy. So again, a multimodal approach, when you're really approaching the patient from all angles that may benefit them, seems to do absolutely great. This isn't the only study I've seen of this. I've seen lots of others when you combine adjusting with manual therapy, especially instrument work along the neck, reduces pain and disability. There's now this one as far as manual therapy and cervical radiculopathy. And I'm sure adding an additional exercise, we're just going to compound these effects. So this is just repeating what I've been talking about for a while, but now we get a systematic review and meta-analysis to show that. Let's go with this one next, actually. Acute and chronic care needs from the Global Burden of Disease study in 2019. Long story short, it's a lot of conflict of interest because it's just a global burden disease study. So it's just a discussion essentially looking at the going over a lot of the factors, discussing what's going on as far as resources, how they're allocated between acute and chronic care. And they're finding that a majority of what is actually happening here is, let's jump here, things to know. So data was analyzed by age, sex, sociodemographic index, and contributions to burden metrics such as disability adjusted life years. So that's an important factor, disability adjusted life years, DALYs, years lived with disability, and years of life lost. So that's the important vocab. When they reviewed the data, almost 70% of disability adjusted life years were attributed to chronic care, while only 27% were due to acute. Chronic care needs increase with age, representing 86% of years lived with disability and 71% years of life lost, and accounting for 93% of years lived with disability from downstream effects, sequelae. These findings highlight that chronic care needs far exceed acute care needs globally, and that they say that healthcare needs to adapt accordingly. This is why our clinic is set up the way it is. We see this so much that patients, whether it is in the acute stage where they go in and get taken care of, which is how a lot of systems are set up, we hear this story all the time. It's usually 6 months to 2 years is the average range at my clinic that a patient has a certain condition that they were getting treated for a little while. Now, some of these people let the condition go and they don't seek further care until they see me. Others go through the gamut of other providers. Basically, the system is not set up to take care of these chronic conditions when they become chronic because they take such a multimodal approach. And too often the system is set up for high volume, high speed, maximizing the provider's time to patient ratios. So even if somebody says, well, yeah, but my patient was at my clinic for, an hour, odds are good that they saw a initial contact provider an administrator for the first 5 to 10 minutes, then a low-level practitioner, basically taking vitals and the basic notes, etc. The actual doctor or treating physician was there for 5 to 15 minutes, and the rest of the time was spent through whether it was musculoskeletal manual therapy, uh, physiotherapeutics, devices, TENS units, STIM, lab work, etc. So the patient was there for a long time, but people actually taking care of them consistently was not. They were just maybe half a dozen people all doing their little part, and the person just felt lost. I'm getting off point here. Long story short, they get to me and we actually take our time to address this burden, because a lot of this can be fixed not with some newfangled treatment, not with something the patient maybe not hasn't had before, but the approach itself, where we take our time, we get the history, and we understand the person in front of us, really starts to address a lot of the facets that contribute to this chronic pain and this chronic disease issue, where by getting to know them, we know their goals, we know what's stopping them, we get a rough estimation of where they're at mentally. We use yellow flag questionnaires to see if there's any catastrophizing, movement fear, kinesiophobia, if there's any metabolic conditions, comorbidities that we need to either address in clinic or refer to other providers for. We have an idea of where they're some patients, if they're open to it, their social network, their support system, if they're currently moving, how's their diet, how's their sleep, what's their stress level at, on top of what physically do we need to address to get them to move, and really taking all of these pieces to fit it together to make sure that we are doing our part at least to address these chronic care needs, because they're only going up, they're only getting worse, the system isn't set up for it, and we need to make sure that we're taking care of these people, and it's only going to grow bigger. Now, last one kind of touches on that a little bit. It's kind of cool, and I'll end on this study. Foot pressure in patients with chronic lumbar radicular pain, aka sciatica, caused by a legitimate lumbar disc herniation, case-controlled observational study. So basically, they had 30 healthy controls that they put through this pressure plate monitoring, and then 41 patients with sciatica. And what they found was the patients with sciatica had longer contact time, so more time actually pressing down on the gait plate and pressure sensor, the foot scan platform. Higher mean and peak pressures in all foot zones, except for the first metatarsal and toes. Pressures were higher in the third to fifth metatarsals, especially when you tried to push off. So use that foot again. So patient's foot lands on device, they distribute their weight through, and then they go to toe off to actually propel themselves forward. And they had an especially high pressure during that. Patients with also sciatic arthritis experienced not only low back pain, but also lower limb and foot pain, as well as higher foot pain related disability. Essentially, their conclusion, altered plantar pressure distribution in patients with sciatica could be associated with a compensation mechanism. I'm inclined to agree. I have a person with sciatica right now that is noted. They walk different, especially if there's a flare-up. If they're doing fine, they're closer to normal, but they feel like their walk different, their balance is off. The body trying to adjust around the new sensation that it's dealing with sciatica is, of course, going to throw off the extraordinarily complex mechanism that is your gait cycle. It is not surprising one iota. You could throw off your gait cycle by, who's done this? I've walked barefoot and all of a sudden you hit something akin to a Lego, a sharp rock. Part of your foot is bruised. You're going to walk around that bad boy and it's going to feel off for quite a while. And so much weight, so much pressure, so much force goes through the foot, the ankle, and the lower limb, that it, of course, is going to affect things up the chain. It's just a matter of how much, how well, and how can you adapt around it while you're healing. Patients with sciatica, depending on how long it's there, they may just adapt to a new normal for quite a while. And I've seen this a lot, where they will have altered gait mechanics, they will have altered foot mechanics, ankle mechanics, knee mechanics. They will complain about, especially when you start addressing the sciatica, new pains will creep out, like, oh man, yeah, my back is feeling better, my leg's feeling better, but man, all of a sudden my ankle hurts and my knee hurts. Well, we need to address that. We need to take a look at this whole person approach and make sure that we're doing the best that we can to, as you come out of this chronic condition, typically, that we're getting you back to your body's ideal. It's normal, what it likes. So this is, again, cool, tickles my fancy. It's not a surprise at all. I see it all the time. And I think it's just something fantastic to end on. So thanks for sticking with me this far. Until next Thursday. Bye.